Welcome back to the deep dive. I want you to picture a scenario. It is, say, 2:00 a.m.
Always 2:0 a.m.
Always. The hospital is quiet, the lights are dimmed, but you are standing at the bedside of a patient in bed 4. They're in pain. I mean, real pain. And the clock is ticking, and you have to make a decision that could save their life, or if you miss these really subtle signs, it could lead to a catastrophe.
Yeah.
Today, we aren't just talking about medicine. We are tackling what is, for me, the ultimate detective story. We are talking about the acute abdomen.
It really is the classic puzzle, isn't it? I mean, the stakes are just incredibly high, time is rarely on your side, and the clues are often hidden in the strangest places.
Right. It's not always in the blood work or the scan.
Not at all. Sometimes the answer is in the way a patient walks into the room, or the specific tone of their voice, or even, the way they stop breathing for a split second when you press on their stomach.
And to guide us through this whole high-stakes investigation, we are not just winging it. We're going straight to the source. We're doing a deep dive into the definitive guide for surgeons worldwide, Baily and Love's Short Practice of Surgery. Specifically, we're in Chapter 63 of the 28th edition, History and Examination of the Abdomen.
Oh, a legendary text. For generations of surgeons, Baily and Love has been the Bible.
It really has.
In Chapter 63, that is the foundation. It's the chapter that tells you that before you order the CT scan, before you call the operating theater, and definitely before you panic, you have to talk to the patient and you have to touch the patient.
So before we unleash all this knowledge, I want to state our mission really clearly.
Okay.
We are interpreting this chapter. We're pulling out the logic, the physiology, and the mental frameworks to build what I like to call a ready reckoner for your brain.
A mental anchor.
Exactly. We want to give you the hooks to hang the information on. But, and this is a really big but, this is not a replacement for the text.
Right. We aren't just reading it word for word. If you're a medical student preparing for exams or a junior doctor stepping onto the ward for the first time, you absolutely need to read the fine print in the actual book. Consider this deep dive your revision aid, the thing that makes the reading stick when you're tired and studying late at night.
So here's the call to action right up front. After you listen to this, go open the 28th edition to Chapter 63. Look at the diagrams. Read the captions.
Please do.
Okay. Now let's get into the why. We live in the age of the donut of truth, the CT scanner.
The donut of truth. I like that.
You can image anything in seconds. So why are we spending 40 minutes talking about history and, poking bellies?
Yes.
Is this just nostalgia?
Not at all. It's because you cannot CT scan a story. That's the bottom line.
You cannot CT scan a story.
The source makes a very, very strong point right in the introduction. Despite all our technology, the art and science of history and clinical examination remain the absolute bedrock of diagnosis.
What does a scan give you then?
A scan gives you a snapshot of anatomy, what's happening right this second. But the history. The history gives you the timeline, the progression, the context. If you rely solely on technology, you will miss the diagnosis. Or worse, you'll treat the scan and not the patient. You miss the human element, where all the actual clues live.
I love that. So here's our roadmap for this deep dive. We're going to break this down into 4 phases of the investigation.
Okay.
First, the Sherlock scan, what you see before you even say hello. Second, the interrogation decoding the history. Third, what we're calling the wiring of the house, understanding the neuroanatomy of pain.
Bro, why?
And finally, the hands-on, the actual physical exam.
It's a logical flow, from the doorway right to the bedside.
Let's start at the door. Segment 1, the art of gathering information. The text says the exam starts before you even introduce yourself.
Before a word is spoken.
This is the concept of the doorway diagnosis.
Exactly. As you walk towards the patient's bed, you're already gathering data. You need to switch on your observation mode immediately.
What are we looking for?
What's their general appearance? Look at their gait if they walked in. But most importantly, look at their position in bed. This is often the first binary split in your differential diagnosis.
Okay, so a binary split, what are the 2 options?
Are they lying perfectly still, terrified to move? Or are they rolling around in agony, unable to get comfortable?
That distinction feels crucial, so I want to drill into it. Break down the pathology behind that. Why does one patient lie like a statue and the other rolls around like they're on fire?
It comes down to exactly what tissue is being irritated.
Yeah.
So a patient with peritonitis, that is, inflammation of the peritoneum, the lining of the abdominal cavity, will lie perfectly still.
Perfectly still.
The peritoneum is incredibly sensitive to stretch.
Yeah.
Any movement, even a cough, a deep breath, or someone bumping the bed rail, it stretches that inflamed lining and causes just excruciating pain.
So their body just says stop.
Their brain tells their muscles, freeze, do not move.
Okay, so still equals peritonitis. Now contrast that with the rollers.
The rollers usually have an obstruction of a hollow tube. We call this colic. Think renal colic, a kidney stone, or sometimes biliary colic. The body is trying to push a stone through a tube, causing these massive pressure waves. The patient is restless, pacing, rolling around, just trying to find a physical position that relieves that internal pressure.
Then nothing works.
Nothing works. Because the pain is coming from inside a tube, no position helps. You simply cannot get comfortable.
Wow. So before you've even asked where does it hurt, their body language is already giving you this massive clue.
A huge clue.
Peritonitis is static, colic is kinetic. The text also mentions facial expression. What are we looking for there?
Specifically, anxiety and terror. The text emphasizes that an acute abdomen is a terrifying experience for the patient. They feel vulnerable.
Of course.
If you see terror in their eyes, that's a clinical sign. It tells you the urgency. And, practically speaking, if you don't address that anxiety, you can't examine them properly.
Because a tense patient means a tense abdominal wall.
Exactly. If they're scared, their autonomic nervous system is firing on all cylinders and their muscles are tight. You can't feel what's going on underneath the shield of contracted muscle.
Right.
You have to establish rapport, comfort them, gain their confidence immediately. You have to sort of lower the drawbridge before you can inspect the castle.
I like that.
If you walk in cold and aggressive, you've lost the exam before you've even started.
This brings up a modern wrinkle that the 28th edition addresses directly: telemedicine. We do so much remotely now, but Baily and Love draws a pretty hard line here, doesn't it?
They do. They're quite firm on this. Telemedicine has its place, but the source explicitly states that the inability to perform a physical examination is a major handicap.
You can't palpate a screen?
You cannot palpate a screen.
Yeah.
You can't feel rigidity through a Zoom call. If a patient complains of abdominal symptoms that could be acute, a face-to-face consultation is, in their words, non-negotiable. You have to touch the belly.
That's a clear directive. You can't prioritize convenience over safety.
Never.
Now, let's just quickly talk about the environment. The text mentions privacy and chaperones. It seems basic, but why does a high-level surgical textbook spend time on this?
Because it affects the findings. It's all about relaxation again. If a patient is worried that the curtain is open, or if they're uncomfortable being examined by a doctor of the opposite sex without a chaperone present, they will guard.
Involuntarily.
Their muscles will tense up, the exam becomes unreliable. Plus, legally and ethically, a chaperone is essential, especially for intimate examinations.
So the bottom line is,
if the patient isn't relaxed, your findings are essentially garbage. You might miss a mass because the muscle was tense, or you might think there's rigidity when it's just embarrassment.
okay, so we've set the scene. The patient is comfortable. We've observed them from the door. Now we start talking. Segment 2, the history. And we have to start with a quote from one of the giants of medicine, Sir William Osler.
Listen to the patient. He is giving you the diagnosis.
It sounds so simple, but in a busy ER where you have 5 other patients waiting, that is hard to do.
It requires discipline. It really does. It means you start with an open question. Tell me why you're here, or tell me about the pain. And then, and this is the hard part for doctors who love to solve problems, you shut up.
Just listen.
You let them talk without interruption. The source says that the clues in that initial scream of consciousness often identify the organ system involved before you've asked a single specific question.
But once they've told their story, then we have to become detectives. We have to hunt for the red flags. I want to unpack some of these specific historical clues mentioned in the text. Let's start with past medical history. Why does a scar matter so much?
Because the past dictates the present. If a patient has a scar on their belly, a previous laparotomy, your brain should immediately scream adhesions.
Okay.
Scar tissue from old surgeries can act like strings or bands inside the abdomen. They can twist the bowel and cause obstruction years, even decades later.
So it's a huge clue.
It is. Or if they have a known history of diverticulitis and they come in with left-sided pain, well, that's your prime suspect. You aren't starting from scratch. You're continuing a story.
Let's talk about drugs. This is huge. The text calls out a few specific medications that act as masking agents.
Ah, yes.
These seem really dangerous because they hide the signs we're usually looking for.
They are absolutely dangerous. These are the wolves in sheep's clothing. The first one to highlight is beta blockers.
Right, common heart medications.
Very common. But in an acute abdomen, say, a patient who is bleeding internally from a ruptured spleen or has severe sepsis, the body's natural response is to race the heart tachycardia to maintain cardiac output.
It's the physiological alarm system. Pump faster, we're losing pressure.
Exactly that. But beta blockers literally block that alarm. They cap the heart rate.
So what do you see?
The patient could be losing significant blood, but their heart rate stays at a nice, calm 70 beats per minute because of the drug. If you rely solely on the pulse to gauge how sick they are, you will miss the shock until they collapse. You have to look at the med list to interpret the vital signs.
That is genuinely terrifying. It can completely breaks the rules of physiology we learn in school. What else is on that list?
Steroids. Long-term corticosteroids.
Yeah.
Two big problems here.
Okay.
One, they are powerful anti-inflammatories. Inflammation causes pain. So steroids can mask the pain and the signs of peritonitis. A patient could have a perforated bowel hole in their gut, but not look that toxic or feel that much pain because the steroids are dampening the whole immune response.
So they look fine, but they're dying inside.
Precisely. And the second problem, the text notes these patients need perioperative steroid supplementation.
Why is that?
Their own adrenal glands, which produce natural steroids to fight stress, have basically gone to sleep because they're getting pills every day. If you stress their body with surgery without giving extra steroids, they can go into an adrenal crisis, their blood pressure bottoms out, and they can die.
Wow. And lastly, anticoagulants.
Blood thinners, this one's more obvious. If they need surgery, they are going to bleed. You need to know if you have to reverse the drugs before you make a cut.
So we've checked the meds. Now let's talk about the pain itself. The text uses the classic Socrates acronym cite onset, character, and so on. But I want to focus on the mimics.
The grid pretenders.
The text mentions conditions that look like abdominal pain but have nothing at all to do with the gut.
This is the medical trap. You get tunnel vision on the belly, and you forget the patient is a whole person.
Right.
You have to remember systemic diseases. The source lists diabetic ketoacidosis, DKA, and sickle cell crisis.
Okay, so how do they present?
A child in a sickle cell crisis can present with severe abdominal pain that mimics an acute abdomen. A diabetic in DKA can have severe epigastric pain and vomiting. If you operate on them, you make them so much worse. You treat the medical condition, hydration, insulin, oxygen, and the pain just melts away.
And that leads perfectly into our first fictional case study. I want you to visualize this with us.
Okay.
Let's imagine a patient, a 55-year-old man. He comes into your ER complaining of indigestion. He's rubbing the top of his stomach, the epigastrium. He says he had a heavy meal, feels a bit nauseous, maybe a little sweaty. He looks uncomfortable, but not, in agony.
A classic presentation. The temptation, the very, very strong temptation, is to give him a pink lady, an antacid cocktail, and send him home. You think it's reflux or gastritis.
But you, the diligent clinician, remember Baily and Love? You pause. You decide to do an ECG, and boom.
There it is.
ST elevation in the inferior leads. It's a heart attack.
A myocardial infarction. The text specifically warns about this. The heart sits right on top of the diaphragm. An inferior wall heart attack, the bottom part of the heart, can refer pain downwards into the epigastrium.
So to the patient, it feels like stomachache.
It feels exactly like stomachache. To the doctor who's in a rush, it looks like gastritis.
So what's the lesson here?
The lesson is the abdomen doesn't end at the rib cage. Referred pain is a trickster. You have to always look outside the abdomen, especially in older patients complaining of indigestion.
Right.
You cannot diagnose an acute abdomen safely without checking the heart and the lungs. A lower lobe pneumonia can also present as abdominal pain.
Speaking of referred pain and tricksters, that's a perfect transition. Let's move to segment 3, the wiring of the house.
The pathophysiology.
This is the science part of the art and science. This is where we get into the nuts and bolts of why we feel pain where we do.
And if you understand the wiring, you don't have to memorize long lists of symptoms. You can just derive the diagnosis from first principles.
Before we dive into the neurology, I have a check-in question for you listening right now.
Okay.
We just talked about 3 classes of drugs that are masking agents or require special attention in a surgical history. Can you name them? I'll give you a second to think.
Did you get them?
Beta blockers for hiding tachycardia, steroids for masking inflammation and needing supplementation, and anticoagulants for the bleeding risk. If you miss those, Seriously, rewind. Those distinctions save lives.
They really do. Okay, let's talk wiring. The text makes this beautiful, clear distinction between the two types of nervous system supplying the abdomen, the autonomic and the somatic.
And I like to think of this as video resolution.
That's a great analogy. Let's run with that. The autonomic nervous system, which supplies the gut organs, the viscera, the stomach, the intestines, that's like a low-resolution black and white TV signal.
Standard definition.
Standard definition, exactly. It's vague, it's blurry. The gut doesn't have touch sensors. You can actually cut the bowel and the patient won't feel it.
Yeah.
It only knows two things: if it's being stretched or if it's starving for blood, which is ischemia.
So what does that pain feel like?
When the gut hurts, the brain can't pinpoint it. It just knows somewhere in the middle it hurts.
So that's that dull, aching, poorly localized pain right in the center of the tummy.
Exactly. And it follows embryology. Foregut pain from the stomach, gallbladder, pancreas goes to the epigastrium, midgut from the appendix, small bowel goes to the umbilicus, hindgut from the colon goes to the suprapubic area.
So it's all midline and vague.
All midline and vague. If a patient points with their whole hand to the middle of their stomach, that is visceral pain.
But then something changes. The pain shifts. It moves.
And that's when the somatic nervous system kicks in. This is your 4K Ultra HD signal.
High res.
High res. The somatic nerves supply the abdominal wall and the parietal peritoneum, the lining of the cavity. These nerves are precise. They know exactly where they are.
So when the inflammation spreads from the organ to the lining,
the signal switches from low res to high res. That's why appendicitis is the absolute classic example. It starts as a vague ache around the belly button. Why? Because the appendix is midgut. That's a visceral autonomic signal.
Right, low res.
But then, as the appendix gets more inflamed, pus forms and it touches the parietal peritoneum on the abdominal wall. Boom, the pain shifts. It becomes sharp, precise, and pinpoint in the right iliac fossa.
And that shift is everything.
That shift is the wiring changing over from the vague system to the precise one.
To understand where that somatic pain is felt, we need the dermatome map. The text gives us 3 anchors floors in the building, if you will.
These are memory anchors you just need to memorize. If you know these 3, you can map the rest.
Okay, what are they?
T7 is the penthouse, the xiphoid process at the bottom of the sternum.
T7, penthouse, got it.
T10 is the lobby, the umbilicus or the belly button.
T10, lobby.
And T12 is the basement, the pubis.
P7, xiphoid. T10, umbilicus. T12, pubis. Okay, now let's talk about crossed wires or referred pain. We mentioned the heart referring to the stomach. What are the other classics in the text?
The diaphragm is the big one. If the diaphragm is irritated, say by blood from a ruptured spleen on the left side, the brain gets confused. The diaphragm is supplied by the phrenic nerve.
And the rhyme is C3, 4, 5 keeps the diaphragm alive.
Exactly. The nerve roots are high up in the neck, C3, C4, C5. But C4 also happens to supply the skin over the shoulder tip.
Ah, so there's the connection.
So the brain receives a pain signal from C4. It thinks, well, usually C4 means the shoulder. So a patient with a ruptured spleen might complain of pain in their left shoulder tip. It's a crossed wire in the spinal cord. We call this Kehr's sign.
And another big one is the gallbladder.
Yes. An inflamed gallbladder irritates the diaphragm on the right. That can refer pain to the right shoulder blade or just below it in the back. So if a patient has tummy pain and right shoulder pain, you have to think gallbladder.
Okay, before we leave the wiring section, we have to settle a debate. The great colic debate. I feel like patients, and even some doctors, use the word colic to just mean really bad pain. But Baily and Love is very strict about the definition.
Very strict. And definitions matter because they imply pathology. True intestinal colic is a wave.
A wave?
Imagine a peristaltic wave trying to push past a blockage in the bowel. The muscles squeeze hard, the pain rises, it hits a crescendo, and then, and this is the absolute key, it disappears completely.
That's a 0.
The muscle relaxes, there's a pain-free interval where the patient feels fine waiting for the next wave.
So it's like a tide coming in and out, pain relief. Pain relief.
Correct. Now contrast that with biliary colic. The text actually calls this a misnomer.
Not misnomer, so it's not really colic.
Not by the strict definition, no. Biliary pain from gallstones rises insidiously over maybe 30 minutes to a peak, and then it stays there. It plateaus. It hurts constantly. It doesn't disappear completely between waves. There's a constant basal pain.
So it's not a wave.
It's not a wave. It's a mounting pressure in a distended gallbladder.
And your enteric colic. Kidney stones.
That is described as intense, lasting maybe 1 to 2 minutes, radiating from loin to groin. But again, there's usually a background intensity that doesn't fully go to 0. The key takeaway is true colic has pain-free intervals. If a patient says the pain never stops, it might be obstruction, but it could also be strangulation or inflammation.
Okay, we've interrogated the patient. We understand the wiring. Now we finally get to touch the patient.
Almost.
Segment 4, hands-on examination. But wait, don't touch yet. We are still inspecting.
Hands off. Keep them behind your back. You need to look first, and you have to get the positioning right.
How so?
The patient should be flat, one pillow for the head, and, crucially, flex the knees.
Why do we have to flex the knees?
To relax the shield. The rectus abdominis muscles run straight down the front of the abdomen. If the legs are straight, those muscles are stretched tight like cables. If you bend the hips and knees, the origin and insertion of the muscles move closer together. The muscles go slack. Only then can you feel what's underneath. If you don't bend the knees, you're just palpating muscle.
Okay, knees up. Now we look for what I'm calling the paintball signs. These are the signs that look like deep bruising on the skin.
These are rare, but they're incredibly ominous signs of internal hemorrhage. You won't see them often, but when you do, you need to act fast.
What's the first one?
First is Gray-Turner sign. This is a discoloration or bruising on the flanks, the sides of the abdomen. It means there's retroperitoneal hemorrhage.
So bleeding in the back.
The blood is loose in the back of the abdomen, and gravity pulls it down and around to the sides. This is often from severe necrotizing pancreatitis or maybe a leaking aortic aneurysm.
And the other one?
Cullen sign. This is bruising around the umbilicus, the belly button. The mechanism here is that blood tracks along the ligamentum teres, a remnant of fetal circulation, right to the navel. Again, think ruptured ectopic pregnancy or major trauma to the liver.
So, flanks, Gray-Turner, belly button, Cullen. I like the metaphor of internal bruises rising to the surface.
It's exactly what it is. And it can take 24 to 48 hours to appear, so if you see it, the bleed happened a while ago.
What about the overall shape of the abdomen?
You're looking for two extremes. One is the scaphoid abdomen.
Scaphoid.
Scaphoid means boat-shaped or sunken.
Yeah.
You see this in diffuse peritonitis. The abdominal muscles are so rigid and contracted in spasm that they pull the belly flat or even concave. It looks sucked in.
And the other extreme?
Is distension.
Right, the famous F's of distension.
Fat, fluid, flatus, feces, fetus. Although the text focuses mostly on obstruction, which is flatus and feces, and ascites, which is fluid.
And what if the belly is moving?
Visible peristalsis.
Yeah.
This is wild to see. In a thin patient with an obstruction, you can actually see the loops of bowel writhing under the skin like snakes. And the text gives a very specific clue here. The direction of the bean. If you see a bean-shaped loop pointing towards the left upper quadrant, you should suspect a caecal volvulus. If it points to the right upper quadrant, suspect a sigmoid volvulus.
That is high-level detail. The direction of the bean tells you which part of the gut has twisted on itself.
Exactly.
Now, before we start pressing, there's one more test. The cough test.
Please, for the love of medicine, stop doing the rebound test.
Yes.
You know the one where you push deep and let go suddenly to see if the patient screams? That is just cruel.
It sounds cruel. It sounds like something from the Middle Ages.
It's totally unnecessary. The cough test does the same thing, but gently. You ask the patient to cough. Coughing raises intra-abdominal pressure, and it shakes the peritoneum. If they wince and point to a specific spot, that is where the peritonitis is. You've localized the inflammation without hurting them. It also checks for hernia bulges at the same time.
2 birds, 1 stone.
Exactly.
Okay.
Be kind to your patients.
Okay, segment 5. Palpation, percussion, auscultation. Time for another check-in question. We just discussed 2 paintball signs of hemorrhage. Which one appears on the flanks and which one is around the belly button? Pause and verify.
Got it. Gray-Turner is on the flanks. I like to think Turner. Turn to the side. And Cullen is around the center. The umbilicus.
Nice mnemonic. Gray-Turner. Turn to the side. Cullen center. All right, palpation. What are the rules?
Rule number 1, warm hands. If you put cold hands on a belly, the muscles will spasm. You've ruined the exam. Rub them together, put them under the hot tap, whatever you have to do.
And rule 2.
Rule number 2, start away from the pain.
And this is about trust, right?
It's trust in physiology. They say it hurts in the right lower corner. You poke there first, they will tense up the whole abdomen. You'll never feel anything else because you've activated the guard.
So you spiral in?
Start in the left upper corner. Spiral in. And watch their face, not your hands. The face will tell you when it hurts long before they say anything.
We mentioned guarding earlier, but the text distinguishes between voluntary guarding, involuntary guarding, and rigidity. Can you break that down for us?
Okay, so voluntary guarding is the patient protecting themselves. They're anxious, your hands are cold, or you've hurt them. They tense up on purpose. If you distract them, ask them about their holidays, talk about the weather, the muscles will relax.
Okay, so you can overcome it. What about involuntary?
Involuntary guarding is a reflex. The body is taking over. Even if they try to relax, the muscle over the inflamed area stays tight. You can't talk them out of it. It's a true sign.
And the final stage?
Board-like rigidity. This is the end game. This is generalized peritonitis. The entire abdomen feels like a piece of wood. The muscles are in a permanent tetanic spasm to stop any movement of the infected organs inside.
That's a surgical emergency.
An absolute surgical emergency.
Now let's talk about a very specific sign for the gallbladder, Murphy's sign.
A lot of people get this wrong. It is not just tenderness under the ribs. There's a specific technique.
Okay, walk us through it.
Here's the mechanism. You place your hand under the right rib cage, the costal margin. You then ask the patient to take a deep breath in. Now think about the anatomy. As they breathe in, the diaphragm moves down. It pushes the liver and the gallbladder down onto your waiting hand. If the gallbladder is inflamed, cholecystitis, when it hits your hand, it's going to hurt. The patient will suddenly start breathing. There's a catch in the breath. That catch, the inspiratory arrest, is a positive Murphy's sign.
So if they just say, ouch, but keep breathing, it's not a true Murphy's.
Exactly. It has to be that sudden stop.
It's dynamic. They bring the organ to you. Now let's do fictional case study number 2, the mystery lump. You're palpating the tummy and you feel a mass. But the question is it inside the abdominal cavity or is it a lump in the muscle wall itself? How do you tell?
You use the muscles as a curtain. You ask the patient to lift their head or lift their legs off the bed. This tenses the abdominal muscle.
But what happens?
If the lump is intra-abdominal, inside, the tense muscles will cover it up. It will disappear or become less distinct. The curtain closes over it.
Okay.
But if the lump is in the abdominal wall, like a hernia or a lipoma, tensing the muscles pushes it forward. It becomes more prominent. It stands out.
So disappear equals inside. Stays or gets more prominent equals wall. Simple mechanics.
Very simply.
Let's hit the organs quickly. Spleen, liver, aorta.
Spleen, remember, it enlarges diagonally. It grows downwards and medially towards the right iliac fossa.
So don't just feel under the ribs.
No, if you only feel under the ribs, you might miss a massive spleen. Start palpating way down on the right and walk your fingers up diagonally towards the left costal margin.
Liver.
Liver. Palpate during inspiration, just waiting for the edge to come down and meet your fingers.
And the aorta.
Aorta. In a thin patient, you can feel it pulsating, but you need to distinguish transmitted versus expansile pulsation.
What's the difference?
A mass sitting on top of the aorta, like a pancreatic cyst, will just bounce up and down with the pulse. That's transmitted pulsation.
Right.
An aneurysm, a swelling of the aorta itself, expands outwards in all directions, like a balloon inflating. If you put your hands on either side of it, your hands will move apart with each beat.
Yes.
That's expansile. That's the real danger sign.
And finally, sound, percussion, and auscultation.
Percussion is great for telling solid from liquid from gas. A tumor is dull. Gas is resonant. Fluid, or ascites, shifts when you roll the patient over.
And listening with the stethoscope.
Auscultation is mostly about bowel sounds. If you hear high-pitched tinkling sounds, like water dripping in a tin can.
That's mechanical obstruction.
Yes. The gut is fighting to push past a blockage, churning fluid and gas, making those sounds.
And if you hear nothing.
Absolute silence. The silent abdomen.
Ominous.
That is paralytic ileus or peritonitis. The gut has gone on strike. It's given up. And one weird one, the succussion splash.
What's that?
If you shake the patient gently by the hips and you hear a splashing sound like a half-filled water bottle, that's gastric outlet obstruction. The stomach is just full of fluid that can't drain. It's basically a sloshing tank.
We are nearing the end of the exam, but the text warns us about the hidden areas. This is segment 6, the hidden areas and the watchful wait. The text warns against belly button tunnel vision. Where else do we have to look?
You are not done until you have checked the hernial orifices, the groin, the umbilicus, any old surgical scars.
And the text specifically highlights the femoral hernia in obese patients.
Yes, the apron of fat.
Explain that.
In an obese patient, the abdominal panniculus, or fat apron, can hang down and completely cover the groin. You have to physically lift up that apron to check the femoral canal.
Why is that so important?
A femoral hernia is a tight, small defect. It strangulates bowel easily. A small femoral hernia can cause bowel obstruction and gangrene, and it is so easily missed if you don't physically lift the fat and look.
And the other unglamorous parts?
The genitalia and the rectal exam, or PR. The text is clear. Abdominal examination is not complete without a digital rectal exam.
What can you feel?
You can feel a pelvic appendicitis. You can feel tumors. You can check for blood in the stool. It gives you information you can't get any other way. A pelvic appendix might not be tender on the tummy at all, but it will be exquisitely tender on the rectal exam.
Okay, we've done it all. We've looked, asked, listened, and felt. But sometimes we still don't know. And this brings us to the final concept, the value of review or active observation.
This is for the uncertain group. You've examined them, and it's not clearly an appendix, but it's not clearly nothing either.
So what do you do?
The novice surgeon thinks, I must decide now. Cut or discharge. The expert surgeon knows the value of time.
So it's not indecision, it's a plan.
It is a management plan. Active observation. You admit the patient. You keep them nil by mouth. And this is crucial. The same clinician reviews them regularly, every few hours.
You're looking for a trend.
Exactly. Are they getting worse? Is the tenderness localizing? Is the white count going up? Sometimes the diagnosis only declares itself after 6 or 8 hours. The appendix finally touches the wall. The fever spikes.
So you're watching a patient to save their life. It requires patience.
It does. And the text says that in this uncertain group, errors are most common. Rushing leads to mistakes. Watching leads to clarity.
So let's wrap this all up. What does all this mean? We unpacked Chapter 63 of Baily and Love. We've gone from the doorway diagnosis to the hidden hernias.
Let's summarize the Ready Reckoner takeaways.
We'll go for it.
1. Observation first. The exam starts when you see the patient. Gait, face, position in bed, still versus rolling.
2.
2. History is key. Ask about drugs, especially those beta blockers past surgery, and map the pain using the anatomy. 3. Anatomy dictates pain. Vague visceral pain is midline. Sharp somatic pain is directly over the organ, high-res versus low-res.
And
4. Exam logic. Look, then ask them to cough, don't poke yet, then palpate away from the pain, and always, always check the hidden corners like the groin in the back passage.
And finally, never forget the wiring high-res versus low-res and the tricky nature of referred pain.
And remember, at the end of the day, you cannot CT scan a story.
I want to leave you with a provocative thought. We live in an age of instant answers. Google, AI, fast scans. But the text tells us that the most difficult group of patients is the uncertain group, and that is where errors happen. So do you, as a modern clinician or learner, have the patience to sit on your hands and simply watch a patient? Can you tolerate the uncertainty long enough to let the pathology reveal itself? Or will you rush to scan and miss that subtle deterioration?
That is the art of surgery, knowing when not to cut and when not to scan, but simply to watch.
On that note, thank you for joining us on this deep dive. Your mission, should you choose to accept it. Open the 28th edition of Baily and Love, turn to Chapter 63, look at Figure 63.1 showing the dermatomes. Look at the diagram of referred pain sites.
That's all there.
Go read the book. We'll see you next time.
Goodbye.